Bevacizumab is approved obviously for patients based on histology, so those patients with non-squamous tumors, where the later phase trial tested or excluded, patients with squamous cell lung cancers. Those are the people who would be eligible for the addition of bevacizumab. Whereas if it were a squamous cell lung cancer, I would consider something like a platinum doublet with a taxane or gemcitabine, in certain cases with or without nisatumumab. In terms of the benefit, as I mentioned earlier, there is a survival benefit with the addition of an anti-angiogenic agent. So for bevacizumab, the ECOG 4599 trial, it was an improvement in 2 months. And we're also seeing, if you look at the REVEL data and the ECOG 4599 data, that you can improve the likelihood of response or the response rate if you add an anti-angiogenic. Now that does come with a cost, so there are side effects that are mediated by the inhibition of the vascular system, like hypertension, a low risk for clotting or bleeding events that we monitor closely over time. Potentially hypertension is something that we more commonly see in the clinic, but that's something that's easy to manage with antihypertensives for the vast majority of patients. As with any patient with non-small cell lung cancer with stage 4 disease, the goal is really palliation. So the way I explain this to patients is we try to keep your cancer at bay for as long as possible, but we're not smart enough to know how to get rid of your cancer. We're not smart enough to know how to cure you. So the goals are to maintain our quality of life and keep the cancer under control vis-a-vis partial response or stable disease for as long as possible, recognizing that at some point the cancer will learn to become resistant to whatever therapy we throw at it, and we have to keep switching gears. For patients who receive bevacizumab with chemotherapy up front, to monitor for efficacy, we do scans every 2 cycles, and for toxicity, when they come in every 3 weeks for the therapy, there's a detailed physical examination, a history to see how they're doing in terms of their ADLs, and we also look at laboratory parameters like the CBC and a comprehensive metabolic panel, and we follow these serially over time and watch out for adverse events like hypertension that we mentioned earlier. As a summary, the use of bevacizumab in lung cancers was first based on a randomized phase 3 trial, which was the ECOG 4599 trial. These were patients who were treatment naive with a diagnosis of advanced non-squamous lung cancer, and they received or were randomized to carbotaxol with or without the addition of bevacizumab. And we did ultimately the most prized outcome in oncology is an improvement in survival. We observed that with the trial, where the overall survival went from 10-month median in patients who did not receive bevacizumab to a 12-month median approximately in patients who received bevacizumab. This was accompanied by an increase in bevacizumab-related side effects, many of which we've spoken about earlier.